I could talk about good things happening for a month, but let me just hit on a few of them. The first is, I think you know the CCBHC movement, but I'll assume that folks aren't familiar with it. U.S. Senator Debbie Stabenow and Roy Blunt from Missouri put together a bill called the Excellence in Mental Health Act a while back, and it funds actually right now it's over 400 what are called Certified Community Behavioral Health Centers, CCBHCs, across the country. There are also 10 states that are running demonstration pilots, which take a subset of those CCBHCs, use that acronym, and make them part of the state's Medicaid program, either temporarily, like in Michigan at this point, hopefully permanently, or towards moving it to a permanent part of the Medicaid program. CCBHCs actually return us to what John Kennedy signed in 1963, the CMH Act, which meant to set up, which is what CCBHCs will do, is a system that can serve the whole range of mental health needs, from mild to moderate to very severe, including inpatient and outpatient and residential, et cetera, just like the CMHs, but it's regardless of payer. So they're actually financed in a way that allows people from all stripes, whether people have Medicaid, Medicare, private insurance, or no insurance at all, to be treated with that entire range of evidence-based practices. So it's a cutting edge, but only 50 years in coming. So, you know, that's what it took. I guess it's 60 years, almost 60 years in coming. Parallel to that, there is a movement called the Health Home Movement. I think you're familiar with it, but there's the states broadened where behavioral health homes and what are called opioid health homes can be established. It includes most of the state now, both those types of health homes. Those are a little bit different than CCBHCs in that clients or persons served are enrolled in that program if they have, in the behavioral health home side, severe mental illness, on the opioid side, and opioid addiction. And yet what happens, it's a wraparound approach. It says, how do I make sure I work with behavioral health and primary care and housing services and employment services? Sort of like we do, you know, historically with wraparound for adults and kids, but it's the idea that actually there's unique funding to fund non-clinical services, meaning the services that are kind of the glue that fund someone to reach out to a homeless shelter to make sure someone has housing, to pay for short-term stays at residential settings, to make sure the person has transportation. It bolsters what's already in the CMH budget, but to a level that we haven't seen before. I'm glad that Judge Mack is on the call with me. We're really quite proud of the work all of us have been doing the last several years on assisted outpatient treatment and the work on the interface between behavioral health and justice systems. So the AOT initiative, I think you know, started with Kevin's Law in Michigan under Judge Mack's leadership. It's been expanded more broadly. In fact, he and I are working to make sure everybody understands it. It's still not well understood. You know, like everything that's new, it takes a while for folks to believe the old has died and the new is here. But under the new AOT laws, and we're doing, in fact, some work with Wayne State University's Center for Behavioral Health and Justice, they're building a model template for AOT across the state using some of the best practices here in Michigan. And we'll be rolling that out, or they'll be rolling that out in the coming months. It's already online. I'm sure you'll hear more about that in the future. But it takes the best practices from judiciary, law enforcement, and mental health, and says, how can we make sure people get kind of treatment they need, even when they're somewhat resistant? It also gets us out of the old model of no involvement with a person who's having a mental health crisis or an extended one, and the other extreme of putting somebody in a hospital against their will. Judge Mack and I are on the same page in so many ways, saying there's that huge middle ground where most people can be treated in the community, in their homes, with their families, and become restored or recover to a way where inpatient care isn't needed. Similar with incompetent to stand trial, currently, I think you know, or actually prior, that when someone is deemed incompetent to stand trial or on their way to that, they are moved to the forensic center. So they're hospitalized against their will. And so Judge Mack and a number of us are working to ensure that if a defense attorney and the judge and prosecutor agree that incompetent to stand trial is appropriate and the person should be restored to competence so he or she can go through the judicial process, that can be done in the person's home. Again, you can see there's a similar theme with AOT and this IST reform, that people can be better treated, in fact, are better treated in their home environment. It's a lot less costly, but it also reduces the chances of someone being taken out of their home environment to be returned home, only to be still in that same valley they were in when they started. So the IST effort would move their mental health treatment to a CMH, often under an AOT, and then the judicial restoration, or the what we'd call the judicial training, would still be done by the courts and or by DHHS, but the mental health recovery work would remain in the CMH system, where the client, in many cases, was getting it prior. 31N, I think you know, was a real boon. It provided dollars to the state's K-12 system, typically through their intermediate school districts, to let the schools hire social workers, psychologists, counselors to provide school-based mental health care. It was triggered actually by school violence that started years ago, and 31N was a great addition to that. In fact, because of this, there are hundreds. I think the last count I saw, there were over 900 clinicians hired in Michigan schools, which is a huge change. I think, you know, over the last probably 40 years, because of really what I would say is insufficient K-12 funding, when schools cut, they cut those kind of things first. Mental health was one of the first things to go. And over time, then school social workers were almost always assigned only to special ed kids. Not that special ed kids don't need it, but the general ed population was untouched by school social workers. School counselors became merely guidance counselors, right? And not that anything wrong with guidance counseling, but if they were ever doing mental health work, that went by the wayside. And same with school psychologists, we're doing mostly just testing for kids. So this allowed a broader group of practitioners to join the school ranks. Department of Ed has been really quite impressive working with our association, excuse me, and Department of Health and Human Services to realize, though, if you add school clinical staff, what we found is they mostly came from the CMH system. So if we had a workforce shortage before, which I'll talk about in a minute, the CMH system had even a deeper one. And so there is a need to raise all boats. So Department of Ed, HHS, and our association, and others, other in the K-12 world, are working to raise all boats and making sure there's financing there for the public mental health system and its provider network to add dollars and pay to attract clinicians to the hard work of community-based care. I mean, it's really hard work. You're dealing with behaviors that are difficult, that involve an awful lot of community-based care. And if you went to grad school to sit in an outpatient office and talk to people who want to be there, the CMH work doesn't fit that model. And so you want to make sure people get a chance to intern at a school or at a CMH or one of its providers and learn the real beauty of community-based care. But I want to applaud the K-12 world and their willingness to work with us and the state's ability to realize that funding K-12 only clinicians actually just robs Peter to pay Paul. And then Peter, being the community-based system, then is left adrift. Last in sort of the great stuff happening is the My Kids Now initiative. I think you know the state was sued in what's called the KB lawsuit. K is one of the plaintiffs, based on the premise that kids can't get enough Medicaid funded treatment. It started with an autism suit, but it's gone broader than that. The state has said to reframe this from a settlement of a lawsuit to a kid-based initiative. Let's reframe it as My Kids Now. And it's working on everything from improving access to crisis response systems, many times mobile systems, under the public system, to crisis response grants to bolster CSUs, crisis stabilization units, and PRTFs, which are, I think you know, psychiatric residential treatment facilities for kids, short-term treatment facilities. They've also formed a loan repayment program to get people to work in the kid mental health system, either the community-based system or schools. I should tell you, within a 2-week window of taking applications, they received over 1,000 applications from clinicians who want to retain their work in the public system. That means schools or CMHs or the provider system. And I think I just recently read this, over 300 have been approved for the CMH system and about the same number in schools. It's quite impressive. That's more of a retention than a recruitment effort, because it's people who are already in the system who had sizable graduate school loans that the system would pay off if they commit to continue to work in the public system. So so the My Kids Now thing continues to develop. and we'll stay with that in a strong partnership with, we meet with that staff every 2 weeks, a number of us do, and we've been quite impressed with their flexibility. I want to talk then about some of the deeper threats to our system. Maybe it's a plague or more than a threat because it's long standing. First one is inpatient psychiatric access. I think you know, getting a kid or an adult into inpatient care for psychiatric care is very difficult, especially if the young person or adult has behavioral challenges. If the person is labile and depressed and has no history maybe of community involvement, they get into an inpatient bed pretty readily because there are enough beds. We've got to be clear. The Hospital Association, a longtime partner of ours, points that out. What they don't have is sufficient staffing or physical plant changes to give individual rooms for people with behavioral challenges. And what you have is people who have a long history with either criminal involvement because they've been arrested by the correction system, maybe sometimes not for violent crimes, but for vagrancy or what I would call crimes of poverty. They may have a co-occurring mental health and substance use disorder condition, but they have behaviors that are difficult to manage in a hospital setting. And so hospitals have a right not to accept folks, and they certainly exercise that right. There's also a lack of state facility beds. State just reduced 70 inpatient beds in the state hospitals, which is about 10% of all the beds. Now they're going to be adding 60 more beds in community-based settings in what I would call high-intensity residential. Those will only be a step down, though, from state hospitals. It'll open up state hospital beds, but there is still a real drought of community-based residential settings that can take people that with behavioral challenges. Most of that problem stems from the fact that law prohibits the use of the legal terms are seclusion and restraint, but you and I would call it physical management. If I have behavioral challenges and I'm in a group home setting or even in an individual apartment setting, the staff might need times to take a knife out of my hand or tell me to don't take the pills that I was going to take, or don't walk out of the facility, or don't fight with someone else. And they may just literally ask me to go to my room or ask me to separate myself. By federal and state law, they can't do that. That's called seclusion. If they then touch me or ask me to put that knife down by grabbing my wrist, that's called restraint. And so we're working with the state to get exemptions to the federal and state rules. That's happening across the country, by the way, because most clinicians and most lay people would say, I would use that kind of seclusion and restraint with my kids or my loved one at home. I should be able to use that with my client if I do it very carefully and only in emergency settings. So here we go. That's what's happening now. The second problem beyond inpatient access is the workforce issue. I think you've seen that in the press over the last 2 years, but it was a problem before that. What's pretty clear, it's across all classifications. So there are about 100,000 people who work in the public mental health system, either for CMH or for one of their providers. And 50,000 of them are what are called direct care workers or direct support professionals. They work in people's apartments or in their day-to-day living. They might work in a group home. They might work in a day shelter, in a day program, using old-fashioned terms there. And because the pay is so poor, we've been working for years to get the pay up. It really is a pay thing. Someone else reminded me, you know the old saying, is the economy stupid? Well, it's the pay stupid. It really is. It's if we can get compensation up, pay and benefits. And most of those workers, by the way, were working, the starting pay before we did some initial work with your help, by the way, was $11 an hour, and McDonald's is paying $14, and with no benefits. And so with your help and the help of a lot of advocates, that was raised to an average now of $14.35. Given some work we did to raise, the most recent bump up was $2.35, but still the average is $14.35. And the average we're finding of low wage workers in Michigan is $18. So we're working on an initiative now with you and others to move that rate up to $18 at least to start with some sort of benefit, either some sort of healthcare benefit, some sort of retirement benefit, because we want people to make a career of direct care work. Our experience has been, given the intimacy of that work, it's everything from feeding, sheltering, supporting, toileting, dressing, supervision during the day. The intimacy is the intimacy we would want if you and I were getting that with somebody who's committed to that work, not somebody doing it for several months. And the turnover rate's about 40%. In some parts of the state, it's 100%. So that would mean that I, as a person being served, might have a worker change every year, sometimes 3 times a year. That's not how you get the kind of care that you want, where it's respectful and dignified and also science-based. So we're working to move those salaries and benefits up. we're finding there's an incredible workforce shortage also in social work, counseling, psychiatry, nursing. So we're working, all of us working hard. And that's again, a pay thing. There's a second part to both of those though, beyond pay, it is the image. For the last several decades, teachers, law enforcement, and the helping services, including the mental health care, have been denigrated by a number of folks. And so it doesn't appear to be a very attractive place to work, even though you and I know who work in that setting, it's very attractive. It really has a soul to it. So we're working with the state Department of Ed, Labor and Economic Opportunity, and HHS on a campaign that will be kicked off soon to get the word out that this work is meaningful, it's vital, it's important, and it's really, it's a calling, I guess, for a lot of people.
Bob, it's 9:20, and before I ask the couple questions that I see, I wanted to see if you could come back to legislation just for a couple minutes.
Thanks, Pat. Perfect timing. Yeah. So, you know, there's been threats since 2016 to privatize the public mental health system, meaning to turn over the reins of that system to the private insurance companies. We can talk for years probably about why the private insurance companies shouldn't have that. But we've been fighting that for years. With your help, have been very successful. During this year, though, there was a set of bills in the House and in the Senate that had some concerns. The House bills were less concerning than the Senate bills. With your help, we were able to fight those back. And we were successful up through term limits. And we all went to bed thinking term limits was, I'm sorry, not term limits. Lame duck was not going to be much of a circus, but it's become a circus. So 2 days ago, the Senate tried to move some bills that would have privatized care to foster care kids, would have moved all the money for foster care kids' mental health and physical health to private health insurance companies, which would do nothing for those kids except give profits to insurance companies. What those kids need is access to mental health care. And that's a result of the way the system's structured. Our system and you came out, and a number of us came out in opposition, and those bills failed in the Senate. Thank goodness. The rumor is they'll be picked up in the House. The way that's done is there will be some mental health bills that have already passed the Senate. They're in the House. This language will be added to those bills. The aim is by some people to pass it in the House and then send it back to the Senate next week and to have it passed. So we are fighting those bills as well. And so we ask for your support in making sure they don't even have bill numbers yet. We don't know what bills they'll be in, but they are bills that privatize the foster care's kids' Medicaid benefits. So Pat, that wraps up my long-winded but quickly presented presentation.
One other question on the matter of healthcare integration. How do you see that moving forward?
Yeah, I'm glad you said right. So integration, in our views, and I think the views of most people who are in the field as well as those served, is integration matters where it meets the person served. So if you were to ask a person served, is your care integrated? And a lot of clients saying, I want my primary care practitioner and my specialist and my behavioral health care practitioner to be talking, or that I get to build a team, a wraparound approach. They also say, though, they want integration with their housing provider, with their jobs provider. If they're a school, they want to make sure if they're a kid, their school's connected. So our view has always been work on the ground. So we do a survey of our members every year, and there are over 600 integrated care initiatives that our members are leading with either primary care settings, emergency rooms, or health insurance companies. In some cases, health insurance companies can be very helpful when they work on the ground. So that's where integration is moving. I want to make sure people know, though, that for a lot of clients, primary care integration isn't their biggest focus. They might have a sense that they want their housing provider to understand that. They want their employment provider. That's what I had.
Okay, one question in the chat room here asking if you could explain the basis for the research demonstrating whether there are enough inpatient beds.
Yep. So I can just explain it to you. What the research found is that on average, only 2/3 of the beds in the state are filled at any one time. So that's low for a hospital. Typically for other types of specialty, they want like an 80 or 90%. So that's low. And in fact, Milton Mack and I have been on calls where sheriffs say, I'll walk in the unit and I'll realize there are empty beds, I can see it. But it's the behavior that the person brings with them that keeps those beds empty, that the hospital isn't willing to take them into a bed, not because it's vacant or not because it's filled, but because of the behavior.
Okay, we have a few more minutes. Does anyone else have any questions? If you could drop them in the chat. Mark, do you have a question? Unmute yourself.
Yeah, thanks. Bob, new models of care. You're assuming we maintain the existing system of care entirely. There are new models of care which transfer some of the mental health issues to other units of government, to peers. You haven't mentioned that. And also even I want to raise the issue of community information centers through libraries. There are many other opportunities to gain workforce and assistance than through a clinical model. Can you speak to that?
We actually agreed, Mark. I'm glad you said it. So yeah, I mean, if you think about the alternative approaches, Michigan's at the cutting edge. We have over 4,000 peers on the payroll, right, already. But I think we're still in the infancy, Mark, right, of the non-traditional work. I mean, it's why a lot of us work in homeless shelters. The libraries, I mean, echo what Mark was saying, they have been the best partners in most urban settings. That's true in rural too. The libraries where a lot of persons with mental health needs who don't have housing or don't have day activities go. And the libraries have been really impressive to provide a warm, welcoming environment. It's a great place to case find, right, to connect with people. I couldn't agree more with you, Mark. I think Mark and I also been working on, though it feels like the slowest boat, first episode psychosis treatment, which I think is really key. Again, a non-standard care, but it's evidence-based and it needs to be, we need to approach it. Thanks,
Hey,
Mark.
Kate Dahlstrom from Traverse City.
Hi, Bob. Quick question. I noticed recently in our news, well, it's been in the state news, that the law enforcement, because they're short on troopers, that they have this, Michigan has a public safety academy assistance program where they will dole out up to $24,000 per recruit to go through the training process. I guess there's 30 million allocated to that. Do we have anything in the works for our social workers and so on?
Kate, you were reading our minds. So the Wayne State University School of Social Work and the deans of all the schools of social work, our association and National Association of Social Workers have proposed that exact thing. In fact, what we're proposing is that, I think you may know this, but there's a thing called advanced standing MSW. If you have a BA in social work, you can go on in a single year get an MSW. We propose that we actually pay people $30,000 for that year to draw them in. We found that a lot of them with their BA in social work leave work jobs paying about $15 an hour and never return to the field. So if we can provide that $30,000, and we found in 3 years we could add 1,000 social workers, and other folks are applying this to psychology and marriage and family therapy, et cetera. So, but Kate, I've been somewhat frustrated with the lack of uptake on that idea. All the schools of social work, NASW and our association see it as a real, far more straightforward than loan repayment. People don't always trust loan repayment since a lot of folks have been burned by it. But what you talked about that state police are doing is exactly what our model calls for.
I want to give a big welcome to a return speaker, Rachel Zaguskin. Rachel has graduated from the University of Illinois at Chicago with a dual master's degree. She received a Master of Public Health with a concentration in Community Health Sciences and Master of Business Administration with a concentration in Business Management. Currently, Rachel works for the Michigan Department of Health and Human Services as a public health consultant, facilitating the Michigan Suicide Prevention Commission, which was initiated by Governor Gretchen Whitmer in 2019 and officially formed in March of 2020. Prior to the grant period ending, Rachel was the contract manager for the Michigan Suicide Prevention Lifeline Grant. She is also the state program coordinator for a new community violence prevention program that will be implemented this year within the cities of Kalamazoo and Grand Rapids, as well as the SAMHSA grant coordinator for 988. Welcome, Rachel.
Thank you. Thank you so much. Thank you for having me. So let us go ahead and get started. So first things first, I just wanted to go into today's agenda, kind of what I'll be covering today. So I wanted to touch on what happens when you call 988, what the process generally looks like, Then I'll give a basic overview of 988 from a federal level, as well as a brief explanation of the difference between MyCal and 988, followed by more specific information in regards to 988 in Michigan. I will then provide some updates on Michigan 988 metrics, and then go into marketing from a national level and Michigan's 988 marketing approach. I will then end with updates and more information on Michigan stakeholder engagement. Just to gauge the audience, how many of you know what 988 is? If you could just throw some thumbs up for me. Or yeah, that works as well. Okay, it looks like quite a few of you. And how many of you have seen our previous presentation about 988 in any capacity? It's like a lot of you as well. Awesome. So what happens when you call 988? So when calling 988, callers first hear a greeting message while their call is being routed to their local Lifeline Network Crisis Center. The calls are routed based on caller's area code. When people call, text, or chat 988, they'll be connected to trained counselors who are not clinicians that are part of the existing Lifeline network. These trained counselors will listen, understand, and connect them to resources if necessary. And if the local crisis center is unable to take the call, the caller is automatically routed to a national backup crisis center. Currently, 988 has 3 extensions to offer. Veterans, service members, and their families can call 988 and press the option 1. For the Veterans Crisis Line, they can dial the extension 2 to reach the Spanish language line. And recently, our newest extension is 3 for specialized support for LGBTQ youth and young adults. For those of you who may not be familiar, even though it seems like most of you are familiar, 988 offers 24/7 calls, texts, and chat access to trained crisis counselors who can help people experiencing suicidal, substance use, mental health crisis, or any other emotional distress. People can also dial 988 if they are worried about a loved one who may need crisis support. So in July 2020, 988 was designated the new 3-digit number. It seems you all kind of really know the basics of 988, so I'm not going to go into too much detail. As of July 16th, the new 3-digit code did go live nationally. NSPL is not going away though. Kind of as noted previously, the 800 number is still remaining active. We're just asking everyone to start transitioning to the new 988 number. It's easier to remember, it's easier to use. Switching to 988 moves NSPL from a standalone line to part of the crisis services system, which has a lot of benefits to it. So MyCal and 988, what's the difference? There seems to be a lot of confusion related to 988 and MyCal. MyCal basically predates 988. So Michigan has already been working on MyCal when 988 was put into effect. 988 is, again, the new 3-digit dialing code for the National Suicide Prevention Lifeline. MyCal staff answers 988 calls, texts, and chats for Michigan. While there are 2 numbers, it is 1 staff. So we just wanted to reduce confusion on that end. So MyCal is not a replacement for the CMHSPs. And we just wanted to note that no one will be required to call MyCal or 988. It's for people who don't know where to go for help or who want phone support. 988 text and chat has gone live in Michigan with the go live on July 16th. However, instead of Michigan centers answering those text and chats right now, the 988 national backup centers are providing text and chat coverage for Michigan. MyCal, or our contractor Common Ground, is charged with being the primary center when it comes to answering 988 calls, texts, and chats that originate from Michiganders. MyCal will be primary for answering 988 texts and chats statewide. But again, kind of as noted, Michigan is still in the development stage for text and chat rollout, the planning and the process. The rollout plan wants to ensure that the MyCal platform can integrate seamlessly with the universal platform, and that is kind of what we are working on at this point in time. This map just serves as a visual representation of Michigan's 988 primary call center coverage areas. Again, as mentioned, MyCal or Common Ground is primarily responsible for answering 988 calls statewide, except for in Calhoun, Cass, Kalamazoo, Kent, Macomb, St. Joseph, and Van Buren counties, where the 3 regional call centers provide primary coverage and MyCal provides backup call coverage for those areas. If you did come to the last time we presented the following 2 slides. I was just going to provide some updates on our progress. So we are working diligently with 988 groups as of right now that consist of the center of all of the 988 Michigan call centers to create common practices and develop protocols on imminent risk. We are still working on the referral and follow-up process. In terms of care coordination protocols, they are in place statewide with every CMHSP, PIHP, and CCBHC. And MyCal can activate face-to-face crisis services in each of those areas. We are still actively working with 911 to coordinate services. As of right now, we did create a workflow document that kind of standardized involuntary emergency interventions. As far as stakeholders, and I will kind of be touching upon this a little bit later, but we did have a kickoff meeting a couple of weeks ago to begin discussions about marketing. For 2023, the plan is to launch our chat and text implementation. We want to still continue to work with coordination with 911. We will be launching marketing in 2023. So we will be focusing on our targeting outreach and support for our high-risk callers, which I'll touch upon a little bit later, focusing on general marketing for 988 in Michigan in 2023. 988 call metrics. Vibrant, which is our vendor for 988, allows calls to ring for 2 minutes at the caller's local 988 centers before it is rolled over to the National Backup Center. This means that the callers will hear about 20 rings before being transferred to a backup center. According to Crisis Talk updates, averages for getting connected are 1 minute for callers, 3 minutes for chat, and 7 minutes for texts. MDHHS recognizes that wait times are too long, and we are focused on continuously improving the speed of answers, in addition to ensuring that centers are both maintaining and perpetually working towards improving Michigan's overall answer rate. And to our knowledge, Michigan is ahead kind of in measuring speed of answer because that's our one of our areas of focus. We continue to increase staff to shorten wait times. And Michigan has a requirement in place for our statewide call centers to ensure their success. Our stated goal was to reach 80% of calls answered within 30 seconds. MyCal is meeting that benchmark. Since August, Michigan's average speed of answer has dropped from over a minute to 27 seconds, with our ultimate goal being to answer 95% of calls within 20 seconds. And as you can see, unfortunately, Vibrant has been going through some issues with transitioning their data collection systems. So I don't have like updated metrics as of right now, just because they're not accurate, but our calls have substantially increased since go live. Michigan 988 centers reviewed requirement standards from Vibrant during a series of work group meetings and created a document outlining agreed upon protocols that all Michigan 988 centers will utilize, which includes but is not limited to ensuring proper policies and data collection methods and/or strategies regarding active risk, imminent risk, and referrals are uniformly collected and adhered to. Currently, Michigan has a referral and follow-up rate of roughly 2 to 3%. We are actively focused on ways towards improving and increasing Michigan's follow-up and referral process. Michigan decided to follow SAMHSA and Vibrant's original recommendations when it came to focus on our infrastructure prior to marketing 988. We were focused first on developing a Michigan-specific strategy for a marketing approach before actively initiating marketing efforts. Marketing efforts will officially start in January of 2023, but at this point in time, if you are planning on marketing or releasing documents with the 988 number, we encourage you to do so. This slide is just a slide that will connect you, either the QR code connects you directly to our MDHHS 988 website / the MyCal website. There's also a link right there for tools for the SAMHSA website, where you can go and you can either order SAMHSA materials with 988 information, or you can print it off, because I believe they're having a shortage of materials. I think it's taking a little bit longer, but there is options to print the materials if you're interested in doing so. From a national standard to advertise 988 to the public, SAMHSA provided these resources for 988 partners to use when communicating about 988 to their audience. Currently, they're still working on their marketing approach, but again, that link will provide you with current resources or how to advertise 988 on your platforms. Prominent component that Michigan determined needed to be considered first was the concept of trust and trust building with Michigan residents. Thus, Michigan initiated initial marketing strategy was to utilize stakeholders and partners existing and established relationships within their communities to bolster and encourage all Michiganders, especially those that may be considered high risk or underserved, to call 988 if they're experiencing behavioral health related distress. Initial public awareness approach focuses on targeting people most at risk for behavioral health crisis through these trusted partners. And we are trying to identify existing communication channels such as patient care materials, newsletters, websites, and school ID cards to promote 988. It's important to us to ensure that there will be tailored support to all Michiganders, and we have vowed a commitment to provide such support. As far as listening sessions, 2 listening sessions were held prior to the planning process of 988, and we are currently in the process of creating a plan to host a series of additional listening sessions to target high risk and underserved groups. We are also actively working with federally recognized tribal nations around 988. So all of these supports are in place. So as mentioned before, we did have a kickoff meeting with all the stakeholders. The intention with the kickoff meeting was to provide general information, answer everyone's questions in one place, and kind of open up discussions for future conversations around necessary materials or necessary strategies for particular communities or particular groups or organizations. Questions that were discussed: what are you already doing in your community to promote behavioral health services? Are there additional stakeholders that you can think of that are not present at today's meeting, but we should reach out to in the future? What are you currently hearing and seeing about 988? Are there unique barriers in your community that we should consider when moving forward with our marketing plan? And there was a pretty good discussion about all of these topics. Emerging themes that we discussed were just general questions such as the answer rates, how we are planning to coordinate with 911, and just future conversations about cohesive partnerships. What's coming and how can you get involved? Again, we'll be hosting a series of breakout sessions to continue conversations about the needs of focus groups. Stakeholders will be contacted for breakout sessions individually based on their availability. If you would like to participate in these smaller breakout sessions for stakeholders, there is a link for a doodle poll, or you can just reach out to me directly. I can send you the doodle poll, and I will be sending out those invitations early next week. And then if you have any other questions related to 988 in Michigan, please feel free to reach out to the email provided. We will get back to you. Questions, comments? And then at the end of this slide, I think it'll be sent out my contact information. If you want to reach out to me directly, please feel free to do so.
Thanks, Rachel. We do have several questions in the chat, actually. So I'm just going to back up here to one of the first ones. Are 988 crisis workers trained and knowledgeable in IDD and autism?
So at this point in time, I don't believe they are. However, we have noted like autism as a really important area of concern. So we will be focusing on autistic populations for our listening sessions. Again, at this moment in time, there is no training that focuses on that, but the whole point of our smaller breakout sessions is to identify those needs and address them and see what kind of training, what kind of documentation, what kind of resources are needed, and move forward that way.
Okay. Michelle just wanted to say thank you for the LGBTQ specialty. She thinks that's excellent, and thank you for sharing that. Carly said, when did the third extension for LGBTQ plus youth become live?
I believe it was last month. I don't know the date off the top of my head, but I did present to the Michigan Suicide Prevention Commission with updates, and that was one of them. And I believe that was a month or two ago.
Okay. When we call the Lifeways crisis line, we get an answering service protocol. They are very bad. They tell us to call the police and that maybe the police can get us in touch with a mobile crisis. Do you think we would get better support by calling 988, or will it just route us back to Lifeways?
I'm not 100% positive on Lifeways. I believe that if you are experiencing a mental health crisis, you should call 988, just because they are equipped with resources to support an individual that is, again, going through a mental health crisis. So I would say, yes, if you're experiencing a mental health crisis or any kind of mental health distress, we encourage people to call 988, just because they are trained in the proper ways to handle the situation and can connect you to the correct resources.
Awesome. I just want to reiterate too that this presentation after today's programming will be sent out to everyone. How can 988 referrals to local agencies avoid being an off-ramp into a bottleneck? Can 988 coordinate with changes to models which expand beyond the existing clinical model?
Could whoever asked that question kind of elaborate on it?
Mark, if you want to go ahead and unmute yourself.
Oh, sure. Thanks, Rachel. This is a great presentation. I can see a lot of progress has been made. Thank you. The problem is the 988 will as likely to refer to local resources. And as long as we have a predominantly clinical model of how to handle mental health crises, it's going to go into the workforce issue, which is a bottleneck. And there's not going to be enough services. So, and that really gets into, can you coordinate 988 with the changes in service systems so that we have a more flexible response to crises that doesn't just go to a clinical system?
We're still actively working on the referral system because we recognize issues like that occurring. We are working with just partners in addition to the call centers to ensure that doesn't happen. But we are using a platform that's through 988 to try to avoid that, but we're still actively working on it.
Mark, do you also want to, you asked, will 988 have a robust CRM
Oh, yeah.
to track
Yeah,
outcomes?
that gets to, Rachel, sorry to be piling on here. The CRM, customer resource management system, which is really common in the profit world to track calls and outcomes and follow up and that kind of thing. Can you speak to that for 988,
Yeah.
Data system? Yeah.
We're actively working on improving it. Again, it's still in the process of that, but that is exactly what we're focusing on to ensure that all of the resources are up to date and all inclusive. So that's something that we're aware of and, again, actively working on.
Yeah.
But I don't have too much information on that as of right now.
Okay. Thanks.
We are aware, yeah.
Carly asked, do these statistics include individuals calling the existing NSPL number? I know it goes to the same place, just wondering if the data was capturing this.
Yeah, so Vibrant had been, and again, kind of mentioned in the beginning, I had been, prior to the ending of the NSPL grant, I was working with call centers across Michigan for NSPL. So I was receiving reports from Vibrant for NSPL calls, and now it just transitioned to 988. So the data that I provided was inclusive. The issue is Vibrant has transitioned for their data collection software, so it's a little bit screwy, which is why I couldn't provide updated data, but that is inclusive of all centers, yes, all centers in Michigan.
Okay. Glenn asked, under what conditions are calls to 988 referred to a local 911 dispatcher?
So that is still a process that we are kind of solidifying with 911. We are focusing on calls of like imminent risk or active suicide attempts. But we are still kind of narrowing out what that looks like in terms of coordination with 911. So I know that didn't really answer the question, but we're working on kind of finding like a protocol for all centers to coordinate with 911 on that end.
Okay. And Kate had mentioned that Iowa is now putting 911 and 988 on police cars. Is that anything that is in the pipeline for Michigan?
It is not as of right now. That's a great idea. Right now in coordination efforts with 911, we're kind of working on things like when to call 911 versus when to call 988. Just the process of how those calls would go in coordination with 911. We are completely open to ideas and feedback. So if you would like to participate in, again, our smaller breakout sessions and give ideas such as that, that's great. We're encouraging kind of any kind of participation or ideas on how we can better market 988.
Okay, thank you. So there's some other, side conversations going on in the chat. And Michelle, I don't know if you want to unmute yourself, if there's any other questions that you wanted to ask.
Hi, this is Elizabeth. May I ask a question?
Yeah.
Go ahead, Elizabeth.
Thank you. Regarding to the sorting of the calls by area code to get them to a geographic location, how does that affect populations, where people have moved from state to state and kept their phone number, or university populations where students are coming from all over? Are they able to reach local resources? Thank you.
So that was a concern for us, like a big concern in the beginning of 988. Unfortunately, at this time, because there's no kind of geolocation, that is an issue. But at this time, just because it is coordinating with the area code, that is an issue of concern, that people that are living in Michigan with a 248 area code would be, or excuse me, people that are living in Florida with a 248 area code would not be connected to the proper service. At this time, we're trying to kind of figure out how to remedy that situation.
Thank you, Rachel, for providing this update on 988 today. Again, everyone, we will be sending out a copy of Rachel's slides to everyone in PDF format. So thank you, Rachel, for being here. We appreciate you taking the time.
Well, welcome back, everyone. I hope you had a little comfortable break. I mentioned earlier that my role, I'm the co-chair and coordinator for Michigan Partners in Crisis, which is an advisory board to MHAM. And we have periodic programs along with MHAM throughout the year. The advisory board meets quarterly and talks about pending legislation and topics of interest in the field of mental health, and particularly how it affects the criminal justice system. So what I'd like to do now is introduce our next guest, Farah Hanley. She is the Chief Deputy Director for Health, overseeing the MDHHS Behavioral and Physical Health and Aging Services Administration and the State Hospital Administration. Between 2014 and 2022, Ms. Hanley was the Senior Deputy Director for excuse me, Financial Operations And she oversaw the agency's budget, contracts, grants, finance and accounting, audit and information technology, financial and support services areas. Oh boy, I mangled that. Previously, she served as a senior deputy director of Central Operations Administration for the former Michigan Department of Community Health, where she oversaw all aspects of the MDCH budget, accounting, purchasing, and audit areas. Ms. Hanley also has served as manager of the MDCH budget within the State Budget Office at the Department of Technology Management and Budget. In addition, she served as a federal health and budget specialist within the State Budget Office. Ms. Hanley has also served as the acting director of MDHHS in early 2019 during the transition to the current administration. I'd like to welcome Ms. Hanley, and we appreciate you joining us.
Thank you. Thank you so much for having me here today. I really appreciate the kind introduction and the opportunity here to be with all of you. As I go through our attendees, you know, I've been in state government for a little bit and have started as an intern working on the Medicaid budget for in the early 90s. And so I remember you, Mr. Shimatero, and others. And it's just really a pleasure to be here in our different, but just as important capacities serving the citizens of our state. So if you don't mind, I would just like to talk a little bit about the department's priorities and where we're going. I think that you all were sort of looking for an update and to talk about some of those issues and a couple of questions that I think some of you posed to me through email. Does that work? Can I just spend about 10 minutes sort of going over? Okay, great. Thank you. I'm seeing heads nods. I appreciate that. All right. Well, again, thanks for the opportunity. I wanted to really talk to you about not only the work the department is doing, but all the coordinating we're doing with our external partners like yourselves, supporting many of these incredible efforts that we're taking underway. You know, when the governor signed the fiscal year 23 budget this summer, she said the budget will protect public health and public safety, expand mental health resources, grow Michigan's economy and workforce, and empower working families and communities. And it really does. Our department is now at $33 billion and we represent about 43% of the state's entire budget. And so of our resources, about 70 to 75% are solely dedicated to the healthcare administration that you described. So our administrative priorities, I think, are really reflected in the fact that we realigned our internal structure to better reflect the need to be prepared for large-scale emergencies and the next health threat, which we all know is going to happen at some point. So what we did was we said, we knew that there was a need for structural and meaningful behavioral health supports, especially as the pandemic revealed and really exacerbated, as opposed to revealed, really exacerbated the need for meaningful behavioral health reform internally as far as our alignment goes. So we now have the adult side of the behavioral health system in line with the physical health side, all under one roof, or one virtual roof in most cases, where we're able to better coordinate internally our resources and our staff and leverage expertise across various areas in our overarching healthcare administration. We were siloed, and we had people with different experiences and different levels of expertise. And we said, there are ways for us to leverage expertise. And so that was the purpose of our alignment. So again, coordinating internally and making sure we're leveraging that expertise. We also, as part of our realignment, took a step back and said, kids have different needs than adults. Mobile crisis services, for example, looks different for kids than adults. So we wanted to, again, bring attention to those behavioral health needs. And we created a new Bureau of Children's Coordinated Health Policy and Supports. to bring focus and attention to those children's needs, including things like a clinical review team and a team of individuals supporting the autism program, and much more, believe me. So we believe our department health structure is really set up for success through a bureau of specialty behavioral health services in the department, as well as a bureau focused solely on children's behavioral health needs. And, but again, things in life are fluid. So we will continue to assess the best fit to accommodate all the challenges and opportunities out there. And we will ensure that we have coordinated and collaborative structure in place to support our providers like you. In terms of our policy priorities, our proposals have really centered on 3 categories: protecting the most vulnerable residents in terms of health and economic stability, prevention programs that meet people's needs and are cost effective, and one of our biggest priorities, expanding access to behavioral health. So I want to start with our kids. We proposed and received funding for a day treatment pilot. And the day treatment pilot is designed for kids who require more intensive support than what's available through conventional outpatient treatment programs. The day treatment program is largely focused on foster care kids, treating problems stemming from traumatic experiences. And, speaking of kids, we also know as a policy priority, we continue to have racial inequities in birth outcomes in Michigan, which are persistent. Black infants are much more likely to die, 2.6 times, in fact, more likely to die than white. And our maternal mortality rates are much higher for Black women than white. So to address this, we propose doulas as a Medicaid benefit. And we know that doulas are these trained birth workers providing the non-clinical, emotional, and physical support to pregnant women. Data does show that doulas provide a safe and cost-effective intervention. So we're very excited about that approval going forward. And there are several new investments in the 23 budget. I won't get into them, but several rate increases. But I really want to talk about behavioral health a little bit more and focus in on it. Over the course of the last 7.5 months since I got this job on March 3rd, I have traveled the state, and actually it's been more than 7.5 months now. I have traveled the state and I've met with behavioral health providers, CMH directors, PIHP directors, advocates, and others to talk about concerns and opportunities. And one question that continues to come up is, there are many questions, one of which is, how are we going to better coordinate care with our behavioral health efforts across behavioral and physical health? So our agency is really committed to identifying best practices for treating the whole person. Last year, we announced the expansion of CCBHC demonstrations with the hope that this model could eventually work across the state. We're evaluating options for further expansion after the most recent guidance from CMS on further growth opportunities. And as many of you know, CCBHCs are one of the state's integration efforts, providing a wider range of services, facilitating access, stabilizing crises, and the like. We are also working hard to address problems with access and capacity for behavioral health services and excessive demand for inpatient psychiatric services. And I know you all have heard about this. And a lot of that demand is either in our state-operated hospitals and centers or residential settings. There are these large-scale wait lists for children's services at Hawthorne Center and capacity issues in the community. So to address this, we received approval to fund 60 placements in intensive community transition-based settings to focus on getting people who are ready to be discharged out of a hospital into a transition program before actually stepping into an AFC home, for example. So we're really pushing through that discharge process out of the state psychiatric hospitals with that transitional level of care. And we've been working with our behavioral health providers. We already have this program, these services in place, and it's really intended to be either a step up or a step down. So someone might be in that transition receiving those services and have to go back to the hospital, but the department is really working directly with behavioral health providers to make those decisions. We're also focused on crisis response. and mitigating the need for the inpatient services with efforts like crisis stabilization units and grants for expanding mobile crisis for kids. All of these efforts, we believe, are really strengthening our continuum of care and hopefully are allowing us to provide that appropriate care when and where people need it. And we're also working on expansion of 2 more units at the Hawthorne Center, Children's State Psychiatric Hospital, to get kids out of EDs and where they need to go. So, and then finally, I will say on this topic, finally, we are excited that the legislature did approve our proposal to build a new state psychiatric hospital to replace Walter P. Reuther and Hawthorne with $315 million of ARPA funding. And we expect that to be a campus of buildings, hopefully developed here pretty soon. So, and that all actually brings us to workforce, which we recognize as a significant challenge. So if you don't mind, I'd like to just briefly touch on that. Our state ranks 3rd in the nation with the highest shortages of mental health professionals. And that is not lost on us in the department. We know that folks, including our own hospitals, are struggling to hire and retain enough qualified staff to provide psychiatric services. And one primary cause we know is lower compensation to our workers compared to the private sector. So at the department, we've developed an all hands on deck approach. We've established a steering committee chaired by myself and Al Jansen, and it's been broken out by various action teams implementing quick short-term fixes as well as strategizing on longer ones. These action teams that are supporting our steering committee are intentionally labeled as action because my background is talk less and do more. So we are, and I think folks who work with me know that it's really important for us to make decisions thoughtfully, but not to stretch out into a belabored process, and implement where we can quick short-term fixes, because we know there are going to be long-term matters that are going to take some time. We've solicited input, but the vision is really simple. We want to develop and implement a comprehensive plan for short and long-term matters, issues to address in the health and human services workforce shortage. So our focus areas are like clinical and non-clinical efforts, workforce credentialing, flexibilities there, and like a communications workforce recruitment and retention campaign. We are doing several things. We're leveraging partnerships with universities, looking at wages, media campaigns to remove the stigma from a behavioral health profession. We are launching other policies that we believe will positively impact workforce access, like a Medicaid policy to allow Medicaid reimbursement for outpatient behavioral health services, provided by graduates of like a master's or doctoral level education training program in psychology, social work, and other types of therapy, so that if an individual's completed all the requirements for a limited educational temporary license, but they have not yet obtained that license from LARA, they can still train. They can still provide services under supervision. Another was like a recent announcement of our ARPA funding to support up to $68,000 of 3-year funding for financial incentives like increased pay and bonuses. So we're working to think as creatively as possible. These initiatives are really going to, we believe, move the needle, but it's not enough. And so we always could use your support, and are already incredibly grateful for many of the effective lobbying efforts you all have had. And if I have a minute just to talk about diversion, I think there's been some questions about the diversion from our criminal justice system.
Yes.
So we recognize there is an overrepresentation of persons with behavioral health conditions in the criminal, legal, and JJ system. There is a jail task force co-chaired by the Chief Justice and the Lieutenant Governor. Prior to COVID, there was one that showed that there's a high prevalence of people in jails who have behavioral health conditions. MyCal really establishes a fundamental shift now accessible through 988, and that really helps to manage behavioral health crises. It allows individuals to receive help from trained counselors. And then only in rare circumstances would public safety need to be mobilized, thus creating diversion opportunities. We are issuing grants for youth mobile crisis and stabilization services. We will be able to issue grants for adult mobile services through funding allocated to the Diversion Council in the 23 budget. We are participating in that mental health diversion council that was established in 2013 to help examine the issue. And this council has really looked at these intercept points at diverting people from the criminal legal system. So there have been a few things we've supported, including cross-training of law enforcement in partnership with the Michigan Coalition for Law Enforcement Education, as well as behavioral health and EMS first responders. We are supporting boundary spanning RFP, if you will. It's been released to fund boundary spanners, and they will research from the Diversion Council. Research has really shown to be effective in linking people to treatment services upon return from jail. We are supporting partnerships with Wayne State Center for Behavioral Health and Justice to provide technical assistance with counties who are working to develop diversion-like strategies across the criminal case process. And we've developed a toolkit for the assisted outpatient treatment to help guide the field on how to help people with serious mental illness and challenges. We have worked with national experts, I'm told, to train evaluators on juvenile competence to stand trial evaluations. We did realign our department to support where we were focused on expanded behavioral health access and capacity. The realignment internally is to have more focus on youth, and part of that involves looking at youth in the juvenile justice system and developing strategies there. And then, of course, the council has invested programs to support youth with complex needs who are kind of court involved. And it's fine. I'll just wrap up here real quick. In terms of statewide efforts and expansion, the Diversion Council is currently working to expand services statewide with each of those intercept points on the spectrum of that sequential intercept model. They're also reviewing responses from the diversion intervention through boundary spanners RFP that we issued that I talked about. And we are finally planning to make a significant investment with our increased funding in FY23 with mobile crisis response initiatives, which will certainly divert people in need of mental health services from the criminal legal system. So I know I've really provided a lot of information. I think we got some very broad questions that we wanted to make sure we addressed. I apologize if I went over my allotted time. I just wanted to make sure that I was as comprehensive as possible. So thanks again for the opportunity.
Well, thank you very much, Farah. We do have some questions, and if you do have a question, please drop it in the chat. We'll try to get to as many as we have. And Rachel, what is your time limitation? Are you good for another 10 minutes?
Yep, I'm fine.
Okay. Oh, first from Colleen, do the action teams include universities in addressing workforce shortages, such as tuition reimbursement? And do they include people with lived experience?
Yes, thanks for that question. Currently, our workforce steering committee is comprised of state folks at DHHS and at LEO and at other agencies to come up with, we've collected kind of that input to come up with that list of what needs to happen. We have several suggestions on tuition reimbursement that is most definitely on the list. We've already engaged our university partners. They're aware of the focus there. We are looking into funding right now. The governor's budget comes out next year. I can't really, in February, I can't really
Frozen presentation here.
divulge what's in there, but I will send a loan repayment, and we have already done quite a bit of that. So I'm getting a note saying my internet is unstable, so please let me know if you're not hearing me well.
We had a brief glitch, but you came back. So good. What about implementing self-direct? This is a question from Rosalie. What about implementing the self-directed services technical requirement for equitable agency rates?
So I am not as familiar with that. I do have members of my team on this call, I think including Kristen Jordan, Stephen Mays is here, I believe, for questions on diversion. I had another individual who's going to be on the call, but he's off today. So if that's something that you'd like to email, I'm happy to get more information on it.
Hi, Farah. You mentioned particularly the children's hospital and the foster care problem. I wonder if you could comment on the current legislative proposal to carve foster kids out and put them under the health plans, which is still apparently active, both in terms of the practicality, whether there's enough to justify a single PIHP for that group, and how that legislation would impact the administration. And then secondly, if you could just briefly comment, communications is always difficult, how best we can communicate with you and the department. The bodies have changed around, which is understandable. You did it for deliberate reorganization purposes, but sometimes we figure we're going to the wrong person. So where's the right way to go?
Yeah, we may have realigned, but I don't think that the people you were usually going to has changed much. But really you want to start with Jeff Weifrich in our area. He is the lead on the Bureau of Specialty Behavioral Health Supports and Services in our department. Weifrich, I'm happy to send his, I think a lot of you may have already worked with him in the team. That's where I would really start. And of course, if you're having unsuccessful communication, absolutely send me an email. It's very important to me that our department is transparent and that those of us who work here are accessible. And
I didn't mean to suggest otherwise. I'm just saying that communications is always a problem because it just is. That's the nature of the world. We no matter how hard you try, we appreciate you trying.
Yeah, we will always strive to be transparent and accessible. But again, you feel free to always email me and I can connect you to the right person if you're not connecting with the right individual. On your first question, we have an executive group that is working closely with the Bureau of Children's Coordinated Health Policy and Supports, and that is working closely with our Children's Services Administration and in our healthcare administration. So it's this cross-departmental group really addressing what to do about children's behavioral health. And when we look at what first came out in Senator Shirkey bills, and then the conversations really evolving to foster care, one of the things we want to do is not close the door to anything that will improve the health and welfare of foster care children. We don't have a formal or official opinion on that particular change, but I will say that we always have our doors open to talking more about how we think we can improve coordinated care. I believe that those bills actually have died anyways, so I think it's in the past, but I'm sorry.
They died and they were defeated in the Senate last week.
Correct.
There's some talk now about trying to resurrect them in the House. I don't know that will happen. In fact, I think it's probably unlikely. But one of the concerns that I had about it was whether you would have if you just, it would create a separate PIHP just for foster care kids. I'm not sure that's a large enough group to make a PIHP work.
Yeah, I really can't speak to the details of any legislation until I read it, but generally speaking, we're always open to discussing ideas.
Fair enough. Thank you.
Okay, next, let's take a question from Kate Dawson.
Hi, Farah. Two questions that are connected to consuming an inordinate amount of the clinician's time. And since we, recognize that clinicians are in short supply, grant requests and the paperwork that they have to do. And grants are especially difficult for smaller and rural agencies because they don't have a dedicated grant writer. Is there any thought to simplify the grant process and maybe combine with site visits or something like that, or to reduce the amount of paperwork, at least for the time being? Are you looking at other states who maybe have a more streamlined system for grants and the paperwork?
I'm really glad you asked that question. One thing I didn't touch on was that we have a administrative oversight exercise that my team is working through to provide me with the ways in which we can improve efficiencies in the process. One of the things that's happened as I've gone across the state is I've heard a lot about how behavioral health providers, CMHs, PIHPs, clinical providers are spending so much time doing paperwork, as you said, and not enough time actually delivering the care. So we are going through contracts, we're going through language, we are looking at requirements. Who's imposing those requirements? Are they state imposed requirements? Are they PIHP or CMH imposed requirements? Are they provider imposed? Like, where are the pain points and what we can do as a state agency to address them? We are looking at everything from network adequacy requirements in contracts to paperwork and duplication. One of the things I couldn't believe when I went to see one behavioral health provider in Detroit was they had an individual come in, and I understand that this is quite common, who had a lengthy multi-hour assessment at the CMH level. And then they came over to the behavioral health provider, and then they were required to do a lengthy similar assessment. Well, this person's in crisis. So there's paperwork like that we're working through to figure out how to create some efficiencies. And I would welcome your input and your feedback if you believe there are opportunities that you think we might be missing.
Thank you. I have I guess it's a comment, maybe a question from Stacy asking about investing in training for attorneys for jail diversion, and I would add deflection, which tends to be a roadblock in diverting and deflecting. And this is a question for Farah.
I'm not following the question. I'm so sorry. Could you just repeat it or rephrase it?
Yeah, I would suggest.
Would you like me to speak to that? I can.
Excuse me, who is this?
This is Stacy. I'm the one that put the.
Go ahead, Stacy.
One of our biggest roadblocks with jail diversions, and we have grants so we have a specific team for jail diversions, but our biggest roadblock a lot of times is the attorneys, prosecuting attorneys and defense attorneys not understanding what we're trying to do, or asking for a lot of things, or just not willing to assist with that because of the risk that it takes with leaving the individual in the community. So some of it is stigma, and some of it is just their knowledge is not there. So trainings for attorneys, prosecuting attorneys and defense attorneys on how we can all work together and build our communities to work together for jail diversions.
Thanks for that. I know that we do have members of our team on this call that spend a lot of their time on jail diversion, and that is the source of their work. So let me connect with them offline, and then we can see if we can get you a good answer. I don't want to put anyone on the spot while we're here, but that's a question we'll take back. I'll commit to us getting back to you on that.
Okay, then, next, let's see. I see a hand up from Maze S1. Go ahead, unmute yourself. You have.
Good morning, everyone. Thank you. Farah, I can address that as my primary role is with the Diversion Council through the Department of Health and Human Services. And I can say that the Mental Health Diversion Council has on its staff a couple of members representing attorneys, both prosecuting attorneys and those attorneys that are working directly with those with mental health issues, substance abuse issues, and developmental disabilities. This issue has come up on occasion through the Diversion Council, and we are working on this to try to get the word out on how to make things a little easier for attorneys to advocate for their clients vigorously through the process. And when we talk about the intercept points on the sequential intercept model, that's where the use of boundary spanners could be really influential in helping to grease the wheels for the criminal justice system and helping to get information to attorneys that would make it easier for them to advocate for their clients. Also, with a prosecuting attorney on the Diversion Council as well, we have some input as to how their limitations might preclude them from being able to offer the assistance that we may ask of them. But that's not to say that they're not trying everything that they can to divert and deflect folks that are coming through the prosecutor's office in a way that's going to both assist the person that's coming through the office and effectively address the issue of public safety.
Thank you. I see a hand up from Mark. Mark, before you ask your question, I also want to make sure everyone knows that the questions are now open for Rachel as well, if you have questions for her. So go ahead, Mark.
Hi, thanks, Farah. Great presentation. One of the, in New York State especially, I'm familiar with the use of technical assistance centers to advance existing models. I mean, even when you have evidence-based programs, you have to implement them properly. It requires technical assistance, and our experience in NAMI and other organizations has been the lack of experience at the local level with diversion 988, CCBHC. Yeah, the range of new demands for service and models for service has left a lot of communities gasping for air. And the technical assistance model seems to offer some relief in other states. Is Michigan considering offering technical assistance to local communities to advance some of these new efforts?
Well, I won't speak on the details because I know Stephen's really much closer to it. I will say this. We are always looking at what other states are doing across the board on various areas and policy that we're working on. And I think actually that's great input. That's really great feedback. I would love it if you had examples of what that technical assistance would look like to send to us, because this is a perfect example of what we could use our new dollars for. So if there is something out there that you think would be beneficial for Michigan to emulate, certainly send it our way. Stephen, I don't want to speak for you, though, if there's something that you believe we're already pursuing that really fits what Mark is mentioning.
Yeah, I could address that actually. The Mental Health Diversion Council has already partnered with the Center for Behavioral Health and Justice. A couple of staff are joining us here as well. So And we've taken it upon ourselves to partner with them to supply the technical assistance that Mark may be referring to in the form of the Stepping Up, the National Stepping Up Initiative. And part of that has to do with the idea that communities sometimes need assistance in just getting themselves together and making resolutions to combat the issues within their community that's holding them back from productive diversion and deflection initiatives. And so the Center for Behavioral Health and Justice helps those communities make those connections with the systems in those communities. And sometimes there's some friction, or maybe these systems have come to loggerheads at some point, and they may need some intermediary help. And so that's where the Center for Behavioral Health and Justice comes in and assists these communities. And it's all free of charge. So these communities can continue to look at ways to get together and get the assistance that they need in order to make that happen.
Thank you. I see a hand up for Leonard, but before I go to you, Leonard, Mark, your hand is still up. Do you have a follow-up? No? Wait, you're muted.
Sorry, this issue goes way beyond diversion and deflection into primary care, healthcare integration, use of peers, alternative workforces that can be used to supplement the overwhelmingly clinical approach that we currently have now that really is leading us into a lot of blind alleys. The clinical approach is overuse of it. So I just want to catch that it's much broader. I didn't mean just to limit it to diversion and deflection. So.
Okay. Leonard, go ahead, please.
Yeah, thank you. And I appreciate Mark bringing up the issue. So I can speak a little bit to the technical assistance that we can offer for crisis response services. So we're partnering with 5 different sites this year to sort of help them map out what are their current crisis resources and where are there some opportunities for growth. So part of that involves sort of process mapping, like what happens when a call comes into, maybe your CMH access line, and how does that flow to different mobile crisis or youth crisis services that are either mobile or not, or different kind of drop-off centers that there might be. And then how does that also look through 911 centers, And so we're also a research center, so we're really data-driven. So one of the ways we do that is to say, okay, how are we sort of tracking where the calls are flowing now? What are your current resources at these different stages? And then how can we work with you to strategically plan how to fill those gaps with your current resources, or if we should look for more resources, whether that's through some of the RFPs coming through the state. And I know there's a number of other philanthropic organizations that are very interested in kind of growing out this space, and we can play a role in sort of making those connections. So I would say if any sort of local community is interested in exploring what that technical assistance look like, we haven't filled out all 5 of our sites yet for this year. So I definitely encourage you to reach out to me personally. We can try to see what opportunities are available.
Leonard, before we go on to the next question, for the people that don't know you, would you just briefly state your connection?
Yeah, of course. Sorry for that, leading with that. So I manage the crisis response projects at Wayne State University's Center for Behavioral Health and Justice out of the School of Social Work. And so we do a number of different research projects about what's happening in the field of crisis response. But as I was just saying, we also can provide some technical assistance in assisting communities building out a crisis system for all the Michiganders in their area.
All right, thank you. Judge Mack?
Yes, I've got a question, Farah. I really appreciate your knowledge here. In the healthcare systems around the state, whenever there's a situation where a patient is injured or killed or was in a situation where they might have been seriously injured, they call it a sentinel event. And that sentinel event is reported. And then they do an analysis of that sentinel event to find out why things went wrong, and in the hopes of correcting it later. So I'm curious if we have something like that in Michigan that covers mental health issues. I'm thinking of a recent police shooting where the individual is on a court order for outpatient treatment, and it appears that the law may not have been followed with respect to handoffs and so forth. So I just wonder whether that's a part of the, a way to improve the system.
Yeah, thank you, Judge, for asking that. It's about operating in the proactive as opposed to the reactive, right? We can say, well, this individual did this, or this individual's in crisis, let's address it. But if we could take a step back and actually address the core root issue of what's happening, that is a different strategy. And that's something we're really working hard to do. That goes back to my focus on foster care kids and what we're doing with day treatment programs, for example. We're trying to catch individuals with high adverse childhood experiences in that example. So because we know that a lot of those kids do end up in our criminal justice system. We want to prevent that from happening. So I couldn't agree with you more. We're looking at things like social determinants of health. Where can we help people make sure they have transportation so they could go to work and actually be productive members of our society and have a purpose? Where can we address childcare so individuals can have supports there? A lot of individuals really don't care about their healthcare. They just want to make sure they have a roof over their head. How can we use Medicaid to support housing? Food shortages and food deserts are another one. So we do, I'm not sure if I'm directly answering the question, but I think what we are doing is taking a step back and trying to get to the root cause of what's happening and operating in the proactive rather than the reactive. So I hope that helps, but that really is a focus of ours.
I appreciate that. What I'm really looking at is in healthcare, in hospitals, they identify sentinel events. And I wonder, it seems that maybe we should be doing that in the mental health arena too. Identify a sentinel event and then do a root cause analysis. Why did this go wrong? Mm-hmm. And I think in the particular case in Detroit, we don't know what went wrong, but we do know the gentleman was on an order, and it appears there may not have been the statutory handoff in this case. So
yeah, let us take that back. And I'd like to talk to our CMH partners as well and see how that fits into the existing structure we have in place. So I appreciate that very much.
Thank you.
Thank you.
I would like to thank everyone for joining us today. We had a wonderful turnout. And we've got a lot of people in attendance that have a wealth of knowledge and experience in the field. So again, thank you. You can join MHAM. There's Mary Ann. Mary Ann Huff is the executive director of MHAM, and she would like to say a few words.
First of all, I want to thank all of you for joining us, and thank you, Farah. That was a great presentation and a lot of great information. I want to thank everyone. So be on the lookout for more MHAM webinars. And also we do have a membership that includes a monthly electronic newsletter with a lot of public policy information. But I just really want to say thank you to everyone for joining us today. I hope that this was helpful, and I hope you have a great weekend. Thank you.